Good afternoon, my dear colleagues. We are very delighted here to have you on the first day of the annual meeting of the ESCTS. I'm so happy to have my dear friend, Dr. Ahmed Eissa. He's a senior fellow of thoracic surgery at Southampton University. What's your impression, Dr. Ahmed?
Thank you very much, Dr. Hatem, for your kind words. So far, I think it's brilliant. Weather is nice. We are on a very beautiful spot of the Mediterranean, and the conference so far is very engaging. Sessions are back-to-back and very useful content. So I think everyone is very excited today about it. And
yes, indeed, we have a very busy program today. We have 7 sessions. We have 3 days of sessions full of very interesting topics. And I would like to discuss a very small topic with you, which is very debatable. If I have a patient who is a frail patient, 70 years old, 80 years old, who has a very small non-small cell lung cancer tumor, which is a peripheral mass, is wedge resection or sublobar resection enough for this patient or not?
Well, we have a lot of evidence coming recently about these patients, and there is definitely a room for sublobar resection in these patients. The evidence suggests that sublobar resection is not inferior to a lobar resection. And the latest studies, the 2 studies, the CalGB and the Japanese group, they showed that there is definitely a benefit or there is no much difference between a sublobar resection and a lobectomy in these patients. So I think there is more and more evidence to come, and there is definitely a use case for these.
Yes. But as you all know, the gold standard has always been the lobectomy, which is more safe. Everything is feasible. The margins are clear. The nodes are clear. But since the 1990s, all the trials that have been discussed to this regard was not in favoring the sublobar resection. So what do you think that came the sublobar resection back to life, and it's being discussed today as one of the potential solutions for these patients?
I think one of the main reasons is that we are discovering lung cancer early. So a lot of patients in lung cancer screening programs have started to come with a very early stage, like T1A or B.
Yes.
So in these patients, it's feasible to take smaller pieces of the lung. And the evidence, as we said earlier, suggests that the mortality is almost the same. So the disease-free survival is very close. And when patients are frail or they have poor lung function, there is always a tendency to preserve more lung. So the notion has changed a bit, that we are having patients coming with early stage lung cancer. Some of them are frail or with poor lung function.
Yes.
So in MDT discussion, there is always a talk about we need to try and preserve more lung.
Yes.
So since the evidence support this now, there is a drive to try and do more sublobar resections.
Yes, because actually these patients did not have the chance to be cured.
Exactly.
And they were switched either to SBRT or chemotherapy, which was not the idea for these patients.
Yeah.
So do you think there is a difference between to do a segmentectomy or to do a wedge resection in terms of survival or the disease-free survival?
To be honest, I don't think there is not much evidence yet about that.
Yes.
And usually it's a discussion of the MDT and a discussion with the patient. And the choice has been always whether the patient can tolerate a more complex procedure, which is a segmentectomy,
Yes.
compared to a wedge.
Yes.
So in frail patients, usually the choice might go more towards a non-anatomical resection.
Yes.
And a segmentectomy in general is more complex than a lobectomy.
Indeed.
It takes more time and requires more planning, especially with VATS.
Yes.
It might be a bit challenging for some segments.
Indeed.
So some segments are easier, we know that, similar to lobes. But when the tumor is more close to the periphery and the surgeon is able to get enough safety margin, sometimes they opt for a wedge.
Yes.
To preserve lung function.
Yeah, I've recently read a paper from Nasser al-Turki and his colleagues he published the post hoc analysis from his scalback trial
Yeah.
for 1305, and he discussed the differences between the segmentectomy and the wedge resections. They provided the evidence that the segmentectomy and wedge resections were not inferior to each other in terms of if you have a very small tumor, which is less than 2 centimeters, that was the cut of value.
Definitely.
And he mentioned that the tumor should be more peripheral to be amenable for wedge resection than the lobectomy. And they concluded that the squamous cell carcinoma were more amenable to do a lobectomy rather to do a segmentectomy or a sublobar resection, by the way. So the evidence now is coming to be more robust. If you have a mass which is 2 centimeters or less, it is peripheral in a frail patient, you can safely just go for a wedge resection plus lymph node sampling, or either a hilar in 1 station and 2 stations, which is the minimum to be, even if the PET scan was not avid, you should do the sampling, which is mandatory. I want to ask you a question. If you have a mass which is a small mass, T1N0M0, and you don't have a pathology yet, would you like to wait for a pathology to be done, or you can go to the patient for upfront surgery?
So thank you very much for this question. I'm actually presenting today about the role of frozen section in these patients. It's a very tricky situation because previously it was always a frozen section followed by a lobectomy. So this was the discussion in the MDT. Now, when you have a very small lesion, we reviewed our data because sometimes in theater you might be faced with a position where you can't feel the lesion, especially with ground glass opacities.
Yes.
And the frozen section might not be feasible, or the lesion is slightly deeper than what you want it to be.
Or you have a long waiting list.
Exactly. And then you discuss with the radiologist in the MDT and they say, oh, we cannot access this lesion. So I think the most important bit of this is the discussion with the patient.
Yes.
Because we need to let the patient know that if we don't manage to get a conclusive frozen section, are they happy for us to go for a segmentectomy straight away? And knowing that they might come back with a benign lesion, for example.
Yes.
So we have data on that. Hopefully I'll present it today. But this is quite tricky in theater because doing a wedge can distort the anatomy for a segmentectomy.
Indeed.
So it becomes a process of planning before the surgery that the surgeon need to put all of these into consideration before consenting and going ahead with the surgery. But definitely there is room for doing segmentectomies without frozen, and there is an increase in the risk that this will come back as benign.
Yes.
But it can happen, and it happens.
But you already have done the minimal as possible.
Exactly. And I think, obviously in VATS, a wedge is easier, but I think with robotics, it becomes simpler to do segments. So this allows more room for maneuvering when the surgeon is faced with this scenario.
Okay. Do you have any preference for the confounding factors, whether to do a wedge resection or to do a lobectomy? Because if you have a ground glass opacity, would you prefer doing a segmentectomy or a wedge?
I think this decision is better to be discussed with the MDT. So obviously every patient is different and lung function for each differs. So a segment is considered anatomical lung resection. So we don't have data yet to support that a wedge will have the same long-term benefit. So I think if the MDT thinks that this mass is more likely to be malignant, and on clinical grounds we think that there is survival benefit, then I think an anatomical lung resection would be better.
Would be the safer option.
Yeah.
Yes.
So what do you think yourself in your practice?
I think in practice it is better to do a segmentectomy or a lobectomy rather than a wedge resection, especially if a patient has a good lung reserve and is a good surgical candidate and can withstand the timing for the segmentectomy. It's much more complicated dealing with VATS to do a segmentectomy than to do a wedge resection. But you have excluded all of the artery, the vein, and the bronchus out of the game.
Yeah.
So there is no rule that a microscopic portion of the tumor is still in there.
Yeah.
So I believe that segmentectomy is much more advantageous than the wedge resection. But we have some cases that wedge resection would be curable to these patients, especially in these frail patients who have a peripheral masses which are small with no nodal involvement. These patients used to have their chance of being cured wasted.
Yeah.
So these patients should now benefit from this, especially with the advent of VATS and RATS.
I think in general it's an evolving topic, and in the future we'll definitely have more data on that. So.
Yes. And I invite all our colleagues to attend this debatable issue. We have a very long session for sublobar resection, which should be at 5 p.m. today at Hall B in the thoracic track.
Right.
I'm very pleased to meet you, Dr. Ahmed.
Thank you
and
very
I wish
much.
to meet you again in
my pleasure.
more interesting topics.
Thank you. Thank you all.
Thank you.